couple of approaches have been explained. One is an para-PSLD or a paraspinal approach where you can directly land on the herniation, and a transforaminal approach which is classically done. But we need to remember that herniations, I'm talking about the 5S1 here, which is extremely tight area because of technical difficulties of high iliac crest, large transverse process of L5, ala of sacrum, narrow foramen, and the large superior articular process. So axis can depend upon, so transforaminal surgery, how you can do, either from medial to lateral or lateral to medial, either way. So it's all transforaminal surgery. So you come from midline to lateral or lateral to midline. So you have problems like pure extraforaminal herniations do exist. I'm not saying that they do not exist, but it usually exists along with concomitant foraminal and lateral recess stenosis. So when you have a multifocal pathology, one single access route transforaminally may not be sufficient to take off the entire herniation, because the trajectory that is utilized transforaminal, that is from posterior lateral axis, is different for lateral recess stenosis and is different for extraforaminal herniations. So you have different kinds of approaches like over the top contralateral axis, where you can come and do a multifocal pathology which involves the lateral recess foraminal and extraforaminal. So I'll just take you to a couple of examples. In situations of high iliac crest, you can definitely do a transiliac approach if there is an isolated pathology in the extraforaminal region. So this is a patient with a extraforaminal herniation. You can see I have marked it in red. It's a large extraforaminal herniation on the right side. So standard access, you be there in the foramen. There's no business inside. But if you can get inside the disc, you can stain the disc. That's the best, because then it will also stain the degenerated nucleus, which will make identification pretty easy. But most of the extraforaminal herniations have displaced, the anatomy is changed, it has displaced the exiting route, so you really don't know where the location of the exiting route is. So it is best to get in caudal at the level of the pedicle, where bone is a definite landmark, and from there you start dissecting gradually and to find your way inside. So this is the needle placement that I have done. I was fortunate enough to get the needle inside the disc. The needle can go inside the disc. Again, we have to remember that the patient is being operated under local anesthesia. Dock your dilator, and once you get inside, the first structure here I can identify is the pedicle. So this is also confirmed radiologically, and then you can see some blue stuff, some fat, gradually mobilizing it cranialwards. So you gradually move. Here the cannula is pretty mobile, because in the extraforaminal zone, the only anchor is the intertransverse ligament. The foramen is actually not an anchor here, because you are outside. So once you see the soft herniation, you start taking it off. Now you should be lucky to get this soft herniation. Most of the times you may not find. It may be collagenized. In that situation, you may have to use a Trefine. So when you get the herniation out, you can see the annular rent. You can see the exiting route. You can probe, because there can be a superior migrated herniation in the extraforaminal herniation. So you need to probe and confirm that there is no superior migration. You can trace the route all the way till it goes extraforaminal, completely extraforaminal. So you can turn your cannula and trace the route all along, so that you have no confusions. Now in situations like this, where you have multifocal pathology, you see an extraforaminal herniation on the left side, you see a lateral recess stenosis, you see a bit of foraminal stenosis, so multifocal pathology, symptomatic side. Best access route for such kind of a pathology would be over the top. So you go to the base, spinolaminar junction, and the base of the spinous process. Drill the base of the spinous process, which can accommodate your scope, and then exactly directly jump over to the opposite side. So once you start seeing the route, you can start decompressing it directly under vision, the extraforaminal component. You can see the exiting route extraforaminally and remove all aspects. And from cranial to caudal, you can trace the nerve route completely. You can also confirm radiologically that you are far out and you are in the extraforaminal region when you do it. Now, fortunately, we were able to get the MRI post-op. So this is the decompression that you will be able to achieve in this case. So advantages of multiple routes and to understand where the pathology lies is important. Multiple access routes are dependent on anatomy and coexisting pathology. This is a targeted surgery, facet joint sparing. And in most of the cases, you don't need a fusion if there is no already existing instability. Recoveries are pretty fast. The patient is able to go home early. Some cases may have dysesthesia, which usually lasts a short time. Dysesthesia is usually temporary, it's never permanent, and settles down most of the times with pregabalin. Very rarely you may have to give a foraminal block, but reassurance to the patient is important that this is going to settle down with time. Thanks a lot for your patient listening.